Craig will introduce our speakers. Bow your heads. In the midst of the church, he opened his mouth, and the Lord filled him with the spirit of wisdom and understanding, and clothed him in the robe of glory. The mouth of the just man utters wisdom, and his tongue tells forth what is just. The law of his God is in his heart. Amen.
Amen.
All right.
Okay. Can you hear me okay?
Yep.
Okay. Our guests today are two members of our church's task force on campus use. They are Steve Simonson, Senior Vice President and Chief Medical Officer of Windtree Therapeutics, a biotech company developing therapies for respiratory disease, and Scott Lockledge, CEO and founder of two nanotechnology startup companies, and he has experience advising Congress and the White House on science policy. Steve's been a member of Westminster for 23 years, and Scott a member for 12 years and a current elder. They and four other lay professionals have been meeting once a month since last May to offer guidance to Pastor Don Lincoln regarding the COVID-19 pandemic and its effect on many church activities, including in-person events. They've taken time out of their busy daily schedules to meet with us, and we're pleased to have them on Zoom. Go ahead, guys.
Great, thanks. Well, why don't I'm going to go ahead and put up a, I'm going to share my screen so we can show a few slides. Can everybody see that now?
Yep.
Yeah.
Yeah.
Good. All right, excellent. Well, Steve and I are going to tag team here a little bit this morning, but we thought we'd just start by telling us a little bit about our backgrounds. Steve, I'll just start, and then please feel free to join in. Then Craig specifically asked us to address a few questions, which I've got here on this first screen under topics. So we'll do that, and then we've got a few other things to talk about. I'm going to talk about masks and some data, data trends and so on with respect to the COVID pandemic, and Steve's got a few other things here. But I'll just talk a little bit more about my professional background. I'm a PhD chemist scientist, a PhD chemist by training. And as Craig mentioned, I have some experience working in science policy. And it really sort of resonated when Don asked me about this, because it really struck me as a situation that was very similar in that respect. That is, we had some big decisions to make for the church, and a big component of that decision was taking into account technical issues, i.e. the biomedical and sort of technical issues surrounding COVID and its transmission. So I was happy to join. The other thing about my background is one of those companies I started, the first company I started was a filtration company. So I'm pretty well versed in the technical aspects of filtration. So I'm going to talk a little bit about masks and as some of the things we're doing at the church in particular with that. So Steve.
Thanks. Good morning, everybody. My background is one from, I began as a pulmonary critical care physician at Duke before moving to this area when I joined the pharmaceutical industry. And currently, as you heard, I'm with a biotech company that's developing drugs for acute cardiopulmonary diseases, including COVID-19 associated lung disease. Sort of as an aside, but related to our task, I'm also on the school board of Unionville Chadds Ford School District. And there, I guess, I serve as sort of the point person for the board in dealing with our administration and external consultants that we have brought in to help us evaluate the ever-evolving COVID-19 epidemiology and infection data, and help to maintain awareness of all the rules and guidances that are coming out from various agencies, from the CDC to the State Department of Health to the County Health Department, and then putting together safety and health plans for the students in our district. So it dovetails very nicely with the activity that we're doing here. And I think you'll see that also in one of our colleagues on the task force. And in addition, I serve that role at my company to help determine how are we going to run our workplace? Should we have people at home or in the office? And so several roles with very similar tasks, trying to adapt to this novel and difficult situation we've been in for over a year now.
Well, great. Yeah, no, thanks, Steve. That's great. So maybe we could move on here and just talk a little bit about the task force. And Steve, I'll just try to address a couple of these questions, and then please, feel free to fill in. But as Craig mentioned, the task force was formed early last spring. As the pandemic was sort of taking on momentum and starting to really take hold around the U.S. And they tasked us with generating recommendations that then go on to session, which is, of course, the ruling body of the church. So the task force meets once a month, and we discuss items usually that Don brings to the table, and then make recommendations on that and anything else that comes up in the meetings. So our meetings are, typically, it kind of depends on what's happening. More recently, we I guess in the last meeting, we're considering not so much issues with closing, but we had to make some issues, or at some junctures, we've had to make recommendations with respect to in-person worship and so on. So we have, we're very fortunate to have the folks on task force that we do. As Steve mentioned, I think he's being modest about that. He's brought, his own perspective, but also, we've been fortunate enough to have the perspective of a pandemic specialist who the Chadds Ford Unionville School Board hired. So we've seen some of that data. And then, of course, on the task force also, we have Jim Scanlon, who's the superintendent of the Westchester schools. So that's a school district with 12,000 students and a couple thousand staff members. So we've had lots of good feedback on that. Steve, anything else to add?
I think you've covered it. The only other way I would phrase some of the questions that Don has brought to us is how do we mitigate that risk and protect the staff and the worshipers and the potential visitors that might be on our campus. But I think you've touched on everything else.
Good, and I think we've been very fortunate that we have the technical skill on our tasks within our staff that we do. The live stream sort of kicked off, and we've been able to reach out and touch an awful lot of people. I think on Easter we had something like 7,000 live or unique hits on the website, which translates into 2 to 3 times that in the number of people. So that's really a wonderful thing that we've been able to do that. Good. Well, so let me.
Scott, can I ask you one quick question?
Sure. Go ahead.
One thing I've wondered about is how much does Don and the task force have to take into consideration with the larger body outside of the church? I don't know if you call it the presbytere or the synod. I don't know the structure from outside of the church in terms of the rules and regulations about COVID. And, because I know Don's trying to get expertise from you but he also understands he hears from the larger church at large about certain guidelines and things to follow. So how much flexibility does he have versus what he's hearing from the larger group?
Yeah, the body's called the Presbytery, and they have made specific recommendations. I mean, we are, as Westminster, one of the largest Presbyterian churches in the country. And so, you know, within our presbytery, we're certainly the largest church. And I think to some degree, people look to us to make certain decisions. And then, you know, we've had a lot of feedback with respect, I think, with what the presbytery's done, you know, as a whole. But we are bound, at least to some degree. I'm not sure what the sort of the legalities of it, but we would certainly be following everything the presbytery recommended. But as I said, it's a pretty tight loop there, and if anything, they're looking to us for, you know,
Thank you.
recommendations.
Thanks.
Yeah. Okay, so let me just spend a few minutes just talking about data trends. I mean, I think early on we were following this really carefully because we, you know, we were making recommendations about in-person worship and all the activities going on in the building, and we wanted to really sort of follow this, you know, very carefully. And so we have, and we've used a number of metrics that we have been following as well to determine what happens within the church. So this is just a graph from yesterday from the New York Times. This shows on the top part, it's cases reported by day. I think it's 7-day averages. On the top is just the number of infections reported. On the bottom is the deaths associated with those days. And as you can see in the spring, when we, you know, in the, sort of the April to May time frame, the infection rates were not that high, but actually the death rates were very high. And this was due to the fact that we just didn't really know how to handle it very well at that point. And also it was making the rounds through, especially long-term care facilities. And that was particularly the case in Delaware County. You know, there was the lag, and then we had a little bit of a bump in the summer, and then here it's really sort of to ramp up in November. So this is a map just of cases around the country from March 11th. So again, this is from the New York Times, and you'll see here in Pennsylvania, March 11, we had 15 total cases. So it was starting to emerge. You know, emerge in New York City and then in Pacific Northwest up in Washington, but it really hadn't hit us yet. But then if we fast forward here to sort of early November, where the second wave really started to kick off, this is what the map looked like, you know, around the country. And so at this point, you know, on November 9th, the major part of the infections, I don't know if you could see my cursor, but are here in sort of the central part of the country. It's, you know, Pennsylvania, we're already well underway with respect to infections, but it's really starting to hit in the upper Midwest. And what was happening here, if you can just sort of, you know, little sort of focus in on some of this, is you see all of these red dots, and those are all localized spots of high infection rates. And it was clear to us at this point, and this was in the November meeting when we made the recommendation to go back to the procedures we were following in the spring. That is, you know, no live in-person worship and no people in the building, essentially. It was clear at this point that the infections were going up very quickly. And if you look at all these lines, you can see some of them are even sort of in a row there, like where my cursor's going right now. And are here, you can see them, all those dots kind of in a row. What's happening there is that the infections were following roadways. And so it was showing, you know, it was quite clear that things were going to take off quickly. If you think about sort of linear growth versus exponential growth, of course, being much more it's going to increase at a much higher rate. All of those spots are indicative of exponential growth because all of them are getting bigger. They're growing radially outward, but in this case, they were seeding. They were sort of moving across. So not only were the dots getting bigger, we were getting more of them. So, I'm back now to this graph I showed you earlier. Right here we are at November 8th, and that's when we made the recommendation to go back and we'd started doing some piloting in-person worship. We ended that, and unfortunately, we were right about that, and infection rates, took off quite quickly, and then the deaths as a lagging indicator, but followed that as well. So here we are currently, we're in one of the worst points to date in the pandemic, and so the recommendations again from the task forces have been to just stay the course. We're not through this yet. We need to just hold off on live in-person worship and keep an eye on things and see how the vaccination process unfolds. Let me just show you just a live map of sort of where we stand now. Yep. Okay, so this is a live interactive map right now. This is the New York Times. And of course, right now, the infections are worst here in sort of Southern California and Arizona, and which you've probably heard on the news, and then here down along the border in Texas, and then the Southeast and South Carolina, North Carolina, and parts of Georgia. The infections rates are high right now. And if we can kind of zoom in here. Let's see if I'm able to do that. Well, I'm not being successful zooming in, but we can kind of step through some of the counties around us. There's Chester County. We're trending downward right now at 34, and Montgomery County 37, and Lancaster County is a little bit higher than us, and I think Wilmington is also a little bit higher. Yes, it's 61. So we followed these trends pretty closely of the counties, Chester County, and the counties around us. So we're trending downward now, but it's still we're still in a hot and heavy stage of the pandemic, so to speak. So that's the recommendations right now of the task force is just to stay the course. So let me just shift now. I'm going to talk. Oh, actually, one other just comment. I've heard a number of people say, "Well, geez, people are dying from COVID, but people die from heart disease and cancer and other sources." Well, here's a graph showing deaths by cause and across the state. And right now, COVID-19 is the leading cause of death. At least it was as of November 28th, and I believe it still is. So yes, in fact, it's the number one cause of death in the state right now. Okay, so let me just transition for a couple of minutes and talk about masks. And there's been a lot of talk about masks and different kinds of masks and so on. We're starting to come sort of full circle, and now in fact, over the weekend, I've heard several stories about about the general population wearing somewhat better masks, and the reason for that is just shown in this graphic right here. When you cough, you exhale particles, and those particles are in the form of aerosols, and it really depends on the size of that aerosol. For the distance it goes, but also for the amount of time that it stays in the air. So, here you can see, for example, a 100 micron particle is going to travel about 2.3 meters under this one. It's going to stay airborne for about 4.9 seconds. And to give you a little bit of perspective on this, a human hair is about 50 microns. So we're talking about something that's like about twice the diameter, a sphere that's twice the diameter of the width of a human hair. But if we get out here to these smaller particles where we're 10 microns, which is about 1/5 the diameter of a human hair, or down around 1 micron, which is 1/50th, then they're traveling much larger distances, and they're staying airborne for much longer periods of time. In the case of aerosols that are single-digit microns, they're spending hours in the air. In this case, it's 12 hours. So, to the extent that you can pull out these smaller particles, which are carrying what are called virons, the live virus, and can cause infection, the better off we are. So just a couple of making a couple of points about the different types of masks and terminology here. We're mostly seeing around today people wearing cloth masks, and then also people wearing surgical masks, and those are very effective. They make a big difference, and it's important that everybody wears those. But those are a little bit different than what's known as a disposable respirator. And so in this case, it's what's called an N95 mask. So the difference there is the N95 mask, the fit around the face is better, and it's really designed to prevent any kind of leakage around the edge of the mask. And then a couple other features of those that they have 2 strands that go around the back of the head, and then a metal nose piece right here, which you can form to fit specifically the bridge of your nose, of the wearer. And then the N95 standard, the N95 standard is a filtration standard. And what that means is that it removes 95% of all aerosol particles that are 3 microns and larger. And this, on this slide, I'm just showing, this is an article that appeared on CNN Health over the weekend, and then they were quoting Tony Fauci, who I think probably most of you have heard about, that an N95 that's well fitted clearly is the best you could do with respect to masks. And this is a graph from a paper that Dr. Simonson shared with the task force, which we very much appreciate. And it just compares the efficiencies of various types of masks. And I know it's probably very difficult to see this on your own screen, but it's got some 2-layer woven nylon masks and cotton bandanas, and they're all 40 or 50 or 75%. The cotton bandana, being on the lower end, at 50%. The gaiters are among the worst, actually. The sort of the pull-up gaiters that people wear over their nose, those are around 30%. But an N95 respirators, in this particular test, is actually showing about 98% efficiency to remove those airborne particles. So, so this is one of the things we did about, in the November timeframe. We located a source for N95 masks, and we made them available to everybody who is doing our live stream worship on Sunday mornings, in particular the volunteers who are running the technical booths. They were doing that. We also, by the way, put in some HEPA filters, which are standalone filters that filter the air very efficiently. So the people back in the control room are breathing, have the option anyway of breathing through an N95 mask, and then they have the air filtered in the background. So that was something we thought we could do, to help mitigate risk. Then just a couple of words here. I know this is probably very difficult, if not impossible to read, but I just wanted to make a couple of points here. If you're interested in wearing an N95 mask, what you'll find is they're very difficult to find. because they're set aside, most of the US production, for first responders. But there are some that you can buy that are a lot more efficient. The so-called KN95, which is a Chinese standard, and you can buy KN95 masks on Amazon, which I'll show in just a second. And then the KF94 mask, and that's a Korean standard. And those, but they're actually, if they do in fact meet the standard, and the Chinese masks, you know, well, who knows? They're probably fine, but I think the South Korean standard is one I personally would be more willing to trust, the KF94s. And by the way, the other thing I read over the weekend is there are several countries in Europe that are now going to be mandating the European equivalent of the N95, which is the FFP2. It's here in this third column right there. And again, I mean, if you go through this this table, which I wouldn't expect you to, but it's pretty much equivalent to an N95 type mask. And again, in all of these, the fit is just important as the filtration material. If you don't have a good fit and you get leakage around the sides, you know, it doesn't work very well. Okay, so I just showing here a couple of quick images. These are 3 of the masks that you can buy on Amazon. Here's a KF94 meeting the Korean standard, the KN95 meeting the Chinese standard. And there's also available on Amazon some Asian-made N95 masks. Those are NIOSH approved, so they've passed all of the US tests, and they have a NIOSH certification number on them. So they should be, unless they're, you know, counterfeits, which I don't believe they are, because this is what we wear in my company. And we've checked it. We've been on the CDC website, checked all of the certifications. You know, those should actually meet the US N95 standard. So I can make this available to anybody who's interested. But that's you know, one of the other things we can do and have actually done at the church to help mitigate risk. Okay, so with that, I'm going to turn this over to Steve. Then I think he's got a few slides and some other comments to share.
Thanks, Scott. Have I effectively shared my screen?
Yes.
What I wanted to do is cover maybe three areas related to COVID. One being some context on why COVID has been a difficult disease to contain, and what is the course of this disease? Because I think we have to know that context in order to appreciate some of the other things that are in the news now, including vaccine and some of the emerging data on new strains of the SARS-CoV-2 virus. And if we have time, maybe I'll throw a provocative slide in there that we'll see if it generates any discussion about where this vaccine should go besides the United States. So at the outset, many of you may remember in 2003 in the church, we had a period of time where we were nervous about SARS, and it never really got to us, but it was in the news and it was caused by a very similar virus. And then in 2012, another coronavirus caused MERS, or Middle East Respiratory Syndrome. And then the big one, COVID-19, which has been with us for a year. And why has this been so difficult to control? SARS and MERS, we don't hear much about those anymore. Why is that? And one of the reasons has to do with how this virus is behaving in the body. And with SARS and MERS, the viral load, or the amount of virus actually in the body, is greatest after you start to get symptoms. So somebody would get sick, they'd be under the care of someone, they could be isolated and contained before they went out into society to spread the disease. With COVID-19, it's almost the opposite. Many people are asymptomatic, yet have a high viral load in their respiratory system, in their nose and in their lungs, or have that before symptoms appear. What you want to do in order to control a disease like this is the three I's of public health: identify cases, isolate the infected, and inform the contacts so that they can quarantine themselves. And that's very difficult to do when you have a disease where 33% of the cases are asymptomatic. And asymptomatic individuals can transmit the virus for up to 14 days. So this allows that virus to be spread unknowingly, and that has been one of the major contributors to the difficulty with this pandemic. So identifying these individuals requires a broader scope of testing than has been done in most places. So how does COVID-19 manifest itself after you get this infection from the SARS-CoV-2 virus? Now look at this data in the context of remembering again that not everybody gets symptoms. But from the time that you might be exposed to someone until you would get symptoms, on average is about 6 days. The median time, or the average time from getting symptoms to getting a test in this country, is about 3 days. So we're already out about 9 days. The average time from symptoms to going into the hospital, if you get so sick, is about 4 to 6 days. So this has a prolonged course before people get under the care or confined care of the healthcare system. Now, if you are hospitalized, about 35% of people end up in an ICU. And that's a higher percentage if you're older, it's a lower percentage if you're younger. About a fifth of the patients, 1 in 5, will end up on a mechanical ventilator. And if you're hospitalized, you've got a substantial risk of mortality. You've got severe disease. The mortality rate for hospitalized COVID-19 patients is about 2.5% if you're under 50, and it's in the neighborhood of 25% if you're over 65. And that number is much better than it was a year ago. I just threw a couple of pictures in. You probably see some things like this on the news. These are not identifiable photographs, but they come from one of the clinical trials that we're doing in COVID lung injury. And this is not an unusual situation in an ICU. Multiple people trying to take care of a critically ill patient. One of the interesting things that has really advanced in the care of patients with lung disease, particularly related to COVID-19, has been the use of something called prone ventilation. And normally you see a person, if they have to be on a breathing machine, they're on their back and they have the tube in their mouth breathing for them. But what we found is that we can ventilate patients much better if we put them on their stomach. That's not always an easy thing to do. It has some risks, but it is one of the advances in care that has come out of this. The other thing that has happened in this disease is the separation of families from patients, and that has been devastating for the mental health of everyone, I think. And this was a picture that got a lot of media attention around the Thanksgiving time, but I think for me it kind of sums up what this disease is all about. And we're treating something that has the potential to be very bad. But is mortality the only thing we need to worry about with COVID-19? And I would say no. It's certainly probably the most important thing. But one of the things that's getting more and more attention now is called long COVID, or COVID long haulers. These are the patients who have had COVID-19 who survive, but they have symptoms that are lasting weeks or months. And about 10% of hospitalized patients may become COVID long haulers. And some of the symptoms that these patients are having are trouble with memory, trouble thinking, they're tired, muscle weakness, sleep problems, anxiety, depression. It's weakness and mental health problems. It's twice as common in women as in men, and the median age is in the 40s. So it's not just a disorder of the elderly, which is where the mortality problem is the highest. There's other things that occur in survivors of COVID that we need to be aware of. And patients who are more severely ill during their hospital stay are more likely to have impaired organ function, particularly the lung if they've been on a mechanical ventilator. But you've probably heard that COVID-19 has a predilection to damage other organs, particularly the heart. And many patients end up with a myocarditis or inflammation of the heart. This can result over time in heart failure, contribute to abnormal heart rhythms and other cardiac effects, even weeks after getting the virus. So with that as a background, obviously we need to solve this problem. And as with a contagious virus, vaccines are our best bet. And I'm not going to spend much time talking about the vaccines per se. That's an area that's outside of my focus and concentration, but we know we have the Pfizer and Moderna vaccines. They are novel in their type. They use what's called mRNA to generate an immune response to get the body to make what's called spike protein from the virus. And these are 2-shot vaccines, 21 to 28 days apart, and they're very effective at what they were designed to do. And we'll come back to that in a minute. We've got 2 other vaccines coming down the pike. The J&J is a little bit different kind of vaccine. It's been designed to be one dose and doesn't need to be kept as cold as the Moderna and Pfizer vaccines. But they're also starting to do trials with 2 doses, and we'll have to see how the data plays out with that. And then there's an Astrazeneca Adenovirus vaccine as well that may be the next one that, well, it's already been approved in some parts of Europe and Asia. So we've had over 20 million doses administered in the United States and probably over 40 to 50 million worldwide. In the clinical trial program, Pfizer had over 44,000 people. Moderna had over 30,000 people in theirs. And the primary thing they were trying to show in these programs was to prevent disease, not infection. Infection is where this virus just gets into your body, but disease is where you start to have symptoms and manifestation of problems. They were both very effective at preventing serious disease. And somewhat uniquely, they were very effective in patients over 65. And that's something we shouldn't take for granted in this program. And the side effects, and they're irritating, but they're transient. They're a couple of days. They're pain at the injection site, tiredness, headache, muscle and joint pain, some chills and fever. And they can be attenuated to some degree by ibuprofen or acetaminophen. And while those are bothersome to many people, I wanted to put it in the context of what we were talking about before, what we're trying to prevent here. This is my provocative slide, and maybe in the discussion, if we want, we can come back to this. But one of my mentors at Duke is Jerome Kim, who is the Director General of the International Vaccine Institute, who has to take a global perspective on the vaccine. And he's raised a few issues that that the world is going to have to deal with. Right now, we've got these phase 3 trials that are designed to demonstrate a reduction in COVID disease, and they've done that. But we don't know what happens after 2 months, and we're continuing to get data there. Will we be protected long-term? It looks like we'll have some degree of protection out for a year, but will we need to be revaccinated? And importantly, we don't know if these vaccines are going to be effective at preventing infection and subclinical disease and transmission of the virus from each other. So we could be protected from getting the disease, but still, after an exposure, spread it to other people. And that's being studied, and we'll get that information in the upcoming months. It's important for us to, as we take a global perspective, to understand that this pandemic is not going to be controlled until there's widespread global distribution of the vaccine. And that's going to take somewhere between 10 and 15 billion doses of vaccine to vaccinate 5 to 8 billion people. And right now, the estimate is that that's not going to be done until 2023 or 2024. And there have been organizations set up, one of them is called COVAX, that tries to ensure equitable vaccine access for every country in the world, to get 2 billion doses out by the end of this year. And they're running into what you might say predictable challenges. The wealthier countries in the world want to grab up as much vaccine as they can. And we're seeing that already, where as of last week, 39 million doses had been administered in the 49 highest income countries, but only 25 doses in the lower income countries. That's not 25 million, that's 25 doses. So healthy adults in rich countries are being vaccinated before health workers and older people in poor countries. I'm not going to make any editorial comment. I'm just stating what it is, and it's an issue that has to be dealt with as we think about keeping this under control. And there's other challenges getting these vaccines around the world. The Pfizer vaccine in particular has to be stored very, very cold, and that's difficult for many third world countries. Storage is a challenge, and in some places there just aren't enough workers to administer the vaccine to a lot of people. And a couple other perspectives about the vaccine. We all want it to protect ourselves and to get back to normal. And as this person, I'm quoting a public health person here, they say it's not just about a subset of patients dying, although that's important. It's about a year of disruption to our lives. And that by getting a vaccine, you're doing your part to eradicate a very serious disease from our society or from the world. And vaccination is just how we handle many contagious diseases that we develop vaccines for, such as measles, chickenpox, things like that. So a bit of a different perspective on the importance of vaccine and perhaps why we should consider getting. Just a quick word about some of the variant strains of SARS-CoV-2. This is, again, not my area of expertise, but it is something hot in the news, and it may impact how the pandemic plays out in the upcoming months. Right now, there's 3 of them that are getting a lot of attention. This virus mutates a lot, but many of the mutations are insignificant. But the UK B117 variant is the one that is starting to circulate in the United States. It's probably been in here in the United States for 3 or 4 months, but we don't do a lot of sequencing in the United States for various reasons. And now that we know that some of these variant strains are coming, sequencing is starting to pick up. But if we're going to keep active surveillance, we need to do more sequencing of the virus to stay on top of this. I'll show you a map in a minute about the UK strain and where it is. There's, I think, 195 isolated infections. Obviously, there's going to be more than that. Until recently, we were saying that this variant was more contagious, but it wasn't more deadly. And then last week, some information came out of the UK where maybe mortality rate is 30% higher. And that data is not strong. It needs to be replicated and more data obtained, but it looks like it may be causing more deaths than the previous strain of SARS-CoV-2. Right now, it looks like the available vaccines will work against this. The South African variant that I don't think we found in our country yet may be less effective with respect to the vaccine, and we just don't know much about the Brazil variant yet. But to the best of our knowledge, it hasn't manifested itself in the US yet.
Hey, Steve, what did you mean when you used the term sequencing?
That's how they determine the
Genetics.
strains of the virus. So what they do is take the nucleic acid and ultimately those code for the proteins. And if this is on the slide here, this orange thing is the virus, and these little things here are the spike proteins. And you can see that perhaps they give an appearance of a crown, hence the name coronavirus for this. But they look at the nucleic acids that code for the proteins that make up these spike proteins. And if those nucleic acids are in a different sequence, or there's a different substitution of one nucleic acid for another, that's what they're looking for. It is the genetic code for how this virus makes the proteins that go into it. And as the virus changes these spike proteins, the spike proteins are probably the most important for these mutations. This is where some of the antibodies are binding. And importantly for the virus, that's how the virus binds to our cells. So this ACE2 is a receptor that's on many tissues of the body, and that spike protein sits right in there. And eventually, once that binding happens, the cell internalizes this virus, and the virus just takes over the machinery of the cell and replicates itself. So that's sort of how this virus works, and why these mutations are important. The UK variant may be much more avidly bound, or it may bind more tightly to this ACE2 receptor, making it more infectious. So that may be part of what is going on there. The dark blue states here are the states where we found this UK variant. I think over time, we'll start to see it everywhere. And there are estimates that say in 2 to 3 months, the UK variant could be the dominant strain in the US, and why it's important to get, there's so much virus out there that we have to get people vaccinated to just decrease the burden of this virus, and there's less to
get the vaccine.
I threw this slide in as a closing to kind of tie it all together. This is a model from the University of Washington, the Internet Institute for Health Metrics, and they sort of model where things are going, and it shows what we should expect for virus and infections in the upcoming months. And it's been a pretty good model to follow. So this is where we are right now. And if we loosened up our social distancing and mask use, this is the kind of curve for number of infections we'd have. They continue to decrease because we're getting into the spring, and the virus decreases to a certain degree as we get out of the winter season. And these are different scenarios based on how fast the vaccine is rolled out. And importantly, this one right here, if we went to a policy of full masking, this green one on the bottom. And you can see that even with these wonderful vaccines we have, the lowest technology tool still adds substantial, significant benefit to us. So everything that Scott was telling us is critically important to prevent spread if we're asymptomatic and don't know it, and to wear good masks to protect ourselves if we come in contact with the virus. And I'll stop there, I think, for the time being. And I know you wanted to have plenty of time for discussion and questions.
Is there any other kind of mask that we should wear other than what's in the local stores, like the CVS and so forth?
He said the K95s and KF94s.
Yeah, I can send around if Ted or Craig wants to distribute that to the distribution list. I can send around the recommendations.
Dave is good at that. Dave Gooddale is good.
Or Dave, yep.
Yeah, Scott, send it to Dave because Dave has the email distribution list for this group.
Sure, okay.
Thanks.
Scott?
I tried to, can you hear me?
Yes.
I tried to walk in the halls of our retirement place and also over at the East Goshen Park that has a loop that's about a mile. And I guess mentally, if I don't see anybody in the hall or ahead of me, I take my mask off. But one of your slides showed that the things that come out of your mouth will hang around a while. So I guess the word there is, even if the hall is empty when you're walking or the trail, it's probably wise to keep it on anyway, so there is no lingering. Am I reading that right?
Yeah, so just maybe a couple of comments there, and then Steve, feel free to chime in as well.
Also, Steve, take the slide off so we can see everybody. Put it back to, gallery view.
So I was just going to say that one of the critical things, one of the things that determine whether you develop the disease or even develop it in your body is your exposure, the so-called viral load. So it depends how many virons you actually take into your body. And, the masks are one of the things that can reduce that. So, so if you're outdoors, your exposure even to just aerosols is going to be less. And so that's probably safer. In the halls of retirement community, of course, that's an enclosed space. And so those aerosols are going to linger longer. But even if you're below, if you don't get the viral load, you won't develop the disease. But the thing that the mask can do is help you reduce, developing the viral load. So to answer your question specifically, it can never hurt to wear the mask, wear it especially whenever you feel comfortable, even if you're outside. But I think in the halls, I would suggest, yeah, you keep it on even if there's nobody in the hall.
Yeah, I would agree with that inside, given the amount of virus that's in that's going around right now, the safe thing to do inside is keep it on. And when you're outside, the diffusion of the virus away is much more effective. And if you don't see anybody around you there, I think it's not an unreasonable thing to take it off.
All right, so those shields that I see a lot of people wearing the shields, they're not very protective, are they? Okay, because I'm saying that because my husband Wayne has a problem wearing a mask. He can't breathe right with it, so it really diminishes his being able to go out and shopping or whatever. So for someone like that, does he have to just stay indoors?
Yes.
Yeah.
indoors with my wife and my cat. Am I to be spared nothing?
Oh, all right. So there's not, I mean, he has to wear a mask regardless, because there's nothing that, if someone can't breathe, you know, he has a problem breathing because of the polio that he had, the lumbar, you know, in his throat when he was young. So he has a problem with that. And that means he just stays in.
I have sleep apnea. I had bulbar polio when I was 8 years old, amongst other maladies. But when I try to walk with a mask on, I have great deal of difficulty in breathing, and it affects my heart.
Yeah, that's a tough situation because there probably aren't a lot of effective alternatives to that kind of face covering for your protection. And the face shields, they may protect others from you because the big particles would hit the shield or be deflected downward and fall faster. But as Scott was mentioning with some of the masks, it's important to have a good seal and fit around your face so you don't entrain air around it when you're breathing in. And there just aren't a lot of other alternatives besides masks. But if you do go out, the one thing I would say is, try to stay away from indoor spaces. Indoor is always going to be more high risk than being outside or in extremely well ventilated places, and stay 6 feet away from people, because that doesn't eliminate the risk from the small aerosol particles, but the larger ones will fall out within that 6 foot radius from people.
On the few occasions where I have gone to the supermarket, I enter with the mask completely over mouth and nose. If I get into an aisle where there's nobody, I will lower the mask off of my nose and just keep it over my mouth. But what you're saying is there could still be these particles floating around, and if I inhale through my nose, then I'm up the creek. And if somebody else comes into that aisle where I am, then I put the mask up over my nose again. But once they leave and I'm alone in the aisle, I lower it so that it's just my mouth that's covered. So that's not really a good thing.
Well, I think that is better than not using the mask. Again, one of the things we have to keep in mind is that to get an infection, there probably has to be a certain amount of virus inhaled into the body. And one of the things that you may have heard about is what constitutes a high-risk contact. And that some of the criteria that they've used for that are being within 6 feet of a person for 15 minutes during a day. And while you can certainly get COVID being next to somebody for a shorter period of time, depending on circumstances, that's what's generally been considered a high-risk contact. So the occasional or the walk-by contact is lower risk, but with the amount of virus that's in our community right now, that's why we're saying wear masks even in the hallways when you're inside, because you just don't know who might have it, and you might not even know that you have it, because like I was showing, over a third of patients or a third of the population who gets this have no symptoms at all, yet they can spread it to people.
Do you have any insight of where Chester County is regarding getting the vaccine?
Yes, and I should have put that slide in. As of last week,
I'm 76, I'm overweight, and I have diabetes. So that makes me extremely vulnerable. And I'm sitting here wondering, and my nails are chewed down to the quick.
Yeah, as of last week, there had been 14,000 doses administered in Chester County. About 9,000 by the health department. And in Delaware County, it looks like about 16 or 17,000. So those numbers should be much higher this week. But
the other thing is you have to register in Chester County. So if you haven't registered online, you need to.
That has been done, but when Chester County Hospital is supposed to be one of the places where you can get the vaccine, and you call there and they have a recorded message that they've got nothing.
But yeah, also any pharmacy, when you go online, they say nothing. There's nothing. We call our doctor, they have nothing. So it's very frustrating, especially when I have a husband like Wayne who can't wear a mask and he's high risk. Very frustrating.
so there may be other health systems within the state that you can try to tap into. I don't know this for sure, but I have been told that the Geisinger system has vaccine, and if you go online, you can try to get an appointment at one of their vaccine clinics, even if you don't live in a particular county where that vaccine clinic is. Vaccine uptake in the middle of our state has not been as good as it has been in the Pittsburgh and eastern part of the state. So they have availability of vaccine.
What was that name again, Steve?
The Geisinger system.
Geissinger, something like that.
A lot of students are struggling with virtual learning. Is it safe for kids to be in school, and are they going to be carrying it to parents and grandparents?
Boy, that's a great question, and that has been it's been a good chunk of my life since last March. I think the most succinct answer is we don't know for sure yet. But even in the past couple of weeks, more and more information is coming out that suggests and confirms what we have thought, that at least in the kids who are under 10 to 12 years of age seem to handle this virus differently than older children and adults. They seem to get the disease less. When they do get it, most of the time it is less severe, and they seem to transmit it less within their families than older people. So I think we're starting to get that kind of good news from more and more studies that are coming in from around the world. US and Germany have just recently put out 2 pretty good pieces of information on that. And I think this will be essential information for us to have to move toward a more in-person education program like we're used to. I think getting teachers vaccinated so that the concern that they legitimately have can be addressed, and they're supposed to be in the category 1B in Pennsylvania. And I think some vaccination clinics are starting to open up to facilitate getting our teachers vaccinated. But you know, I think with the kids and with all of us, we're balancing the very real effects of this virus and infection with it, with the stress and the mental health impacts of this complete disruption of our way of life, and for many people, substantial isolation and loneliness.
A question about masks. It's Sue. Hi. It seems to me that it may be the case that wearing a mask that fits well, that doesn't slide down the nose, that is worn whether or not there's someone near you specifically, actually, could it be a message, a model, a statement that I believe masks are important and I'm wearing it? So I personally just feel as if whether I feel vulnerable or not, I'm going to wear a mask. And yes, then someone else may be vulnerable from me about transmitting. I would love to see really good, well-fitting masks being like almost a symbol of belief in the future that we will conquer this. That's just me in general. But about the global issue of only 25 people in the lower income countries having vaccinations, I believe I heard you say that, well, we've seen the variant from South Africa, one in Brazil. As long as the virus continues to churn in mass in larger populations, the more likely it is for more variants to occur. And not only are those areas that are underserved still hotspots for spreading the virus that we have now, but are potentially the petri dishes for creating new strains. Did I hear that correctly, or did I misunderstand?
If I heard you correctly, I think that's correct, yes.
So then that begs the question, gee, you know, how much more beneficial is it for those of us who, after we reach a critical point of, okay, production is up at a point where by data, we can say it is really advantageous to get this vaccination, you know, globally. What kind of data would indicate to governments that, hey, it's time to go global?
Scott's got the experience in policy. I'm going to kick this one to him because part of in the United States, at least in the recent past, we haven't had as much discussion about getting virus to other parts of the world. In Europe, in the UK, in Russia, those discussions are happening, and various vaccines that are available and being considered for emergency use authorization in those areas are being discussed, and countries are being are engaging with makers to get those vaccines. For example, the Astrazeneca vaccine will be going to some of those countries we're talking about. I don't know the numbers for Pfizer and Moderna. I just don't know it. Some of the vaccine will go there, but I don't know when our health system will be talking more about vaccinating the rest of the world than our citizens.
Sure. I guess with looking at the way data is tracked, and particularly with new strains developing, I just thought there might be a weighted scale of the risks of not spreading or sharing the virus once a certain number of new strains are developing elsewhere. It's kind of can we protect ourselves better by, or protect ourselves after a certain point of inoculation within a specific country? would our protection be even better if we start sharing to beat down the possibility of more variants? I don't know if that question made sense, but maybe it's a mute question. And
I think it does. And I think some of these international vaccine organizations have been trying to make that argument. I've got thoughts on it, but I think they fall in the category of speculation because that's outside of my area of concentration. But I think there's something to that. But the one thing I think we should keep in mind, the mRNA vaccine platform that the Pfizer and Moderna vaccines have been made with, I think does facilitate, if we have to modify a vaccine, I think that it can be done within that kind of platform a bit faster than the traditional kind of vaccines that have been developed in the past. That's just from reading I've done. I don't want to go too far down
that
an area.
road. Thank you, though. Great. Thank you.
Scott and Steve, I have a concern, and it comes out of the fact that I've done research on patient compliance and side effects of drugs, side effects of vaccine, and I've done this for Pfizer and Merck and J&J and a lot of those companies over my 50-year career of doing survey research. And one of the concerns I have is that, as you all know, these drugs, vaccines were rushed to market at a necessity, but we don't really yet know what the long-term effects of some of these vaccines may be. For example, one of the people on the church staff, his wife had COVID a couple of months ago, got the vaccine, and she was really listless for 3 days, and she's had real problems with her eyesight. So, you know, having worked for drug companies, know they're very careful before they bring a vaccine to market. Generally, they look for long-term effects and short-term effects. And that's a scary notion that if the drug vaccine, in fact, can cause eyesight problems. He says she's getting a little bit better with her eyesight, but she's still not quite out of the woods. So, you know, what's your feeling about what the long-term side effects may be when we haven't really gone through the normal testing cycle, which usually takes 8 to 10 years to bring a vaccine to market, and these have been rushed. So, you know, what's your feeling about it?
Yeah. You raised some good points that there has been an acceleration of the process to get these vaccines out to availability. Now, I think there's been 2 places where there's been low or no risk acceleration. One low risk acceleration is that there has been more money put into these programs to scale up. And I'm not talking production here, I'm talking about scaling up programs to get these clinical trial programs done. The second place that I think is low risk has been the amount of money that has been put in to do production scale up at risk. Now, normally, I don't remember exactly what month some of this money started to become available and scale up started to happen, but well over $20 billion has been put in at risk before these vaccines were approved to get production done at risk. And if they wouldn't have met their safety or efficacy targets, there would have been billions of dollars that some would have said was wasted. So that was one place where acceleration occurred, and I think that's low risk. The other thing that I guess I'll say is for a normal drug to be developed, let's say we were developing a drug for asthma. When you go to the regulators to get an approval, you might have 3,000, 4,000 patients in your database of various severities from your clinical trial program. And here, what we have across the phase 2, phase 3 programs across maybe the 4 biggest companies that are putting vaccines out is well over 100,000 patients that have been studied to some degree. Now, vaccines are going to be held to a higher standard than drugs for other diseases. Why is that? Because we're giving vaccines to relatively healthy people to prevent something. Most drugs we're giving to people who already have a disease, and we're willing to accept some degree of risk with them. But so the safety database of these is very large. The other thing is that typically with vaccines, the vast majority of side effects that occur appear within 6 to 8 weeks. Now, we do have a new platform. These mRNA vaccines are new. They could be different, but there's really not an overwhelming body of data to suggest that they will behave differently. So just to sort of sum up my babbling here, I think, we have large data sets where we've looked for these side effects in a very controlled setting. Some vaccine experts say they don't really get comfortable with a safety profile until you get it into about 3 million people. Well, right now we're up in the 20 to 40 million globally, 20 million in the US. So if this plays out like vaccine development has in the past, where the side effects that you're going to see by and large appear within those 2 months of getting the vaccine, we should be okay. But again, there is some risk that something could happen further out than that. And that's part of the reason I wanted to show what we're trying to prevent, because it is a risk benefit calculation in the approval of this. And I would say the older you are, the more detrimental effects of the vaccine that you're trying to mitigate. And each person and their healthcare provider would have to make that decision. But getting this disease, the older we are, the worse this disease can be. The risk associated with it is substantial.
Can I?
Question.
Yeah, this is Dan. I have a question for you. I know you don't have an exact answer to this, but I'd like your thoughts on it. This is getting a lot of press, certainly. But one of the things you see is you'll see someone in their 30s who's been in good health, and in 5 days they're gone, and you'll see someone who is not in that great health and more advanced stage, and they go on, and then they recover. What are the variables, factors from your point of view that are responsible for this?
Boy, that's a good question, and I don't know that answer exists yet. The various susceptibilities that different people have to this virus. Some of it may be related to the size of the inoculum they were exposed to. Some of it may be to conditions that we may not be aware of. Some of it may be genetic. I don't know. I don't have a good answer. I would just be out on a wing there.
What do you think about all this speculation about herd immunity? What's your definition of herd immunity?
Yeah, so herd immunity, I guess, is, as I look at it from a pragmatic perspective, is getting enough people who have had an interaction with the infection or a vaccine that the virus is running out of places to go to spread. And it's related to something called the R0 value for the virus. And that's how infective it is. And if this virus has an R value of about 2, that means for every infected person, they're probably passing it on to 2 others. In our area right now, the apparent R value for the COVID virus is hovering around 1. So that's part of the reason why we're seeing plateauing of infections. That there's still a lot of virus out there, but we're not going up like we were before. I think my personal view is some of the discussion months ago about trying to let the infection spread to get herd immunity through natural infection with this virus is very dangerous because of the susceptibility of different parts of the population, particularly older people, to this virus, and because of the consequences of being infected and surviving, that people are having persistent symptoms for a long time. And the price we would pay to get there would be, as we've seen in some parts of the US, an overwhelmed healthcare system where not only are people with COVID having challenges getting treated, but the rest of the medical ailments that we have are impacted because of the burden of that COVID has put on hospitals. So I think we need to try to get toward herd immunity with vaccine approaches to keep the spread of this virus as minimal as possible.
Steve, the only other comment I would just add there is that Sweden tried that and they didn't have such a good outcome from it.
It's a good point.
Can you tell me, going back to the masks, do you have a guideline on reuse of them? Because I know I'm guilty of it, our family. We will have disposable surgical masks, and we also have cloth masks, but we go and run errands, throughout the day, and we use the same mask, and then maybe it's left in the car, and so the next day we're using it again. Are we setting ourselves up significantly for the contagion to get into our bodies by taking the masks off, putting them back on, off, on? I'm not talking about just adjusting them, but actually taking them off after you've been out and in an enclosed space, grocery stores, wherever, inside, and then you put them back on after the fact.
Yeah, I think that's, strictly speaking, the masks, the surgical masks, for example, that you buy in CVS, those are one-time use, and the intention for those is that they're to be used once and then discarded. I mean, I think a lot of people are reusing them or continue to use them, and there are some risks associated with that. I think I reuse a mask a few times before I discard it and get rid of it. But in general, I think they should, the use should be limited. The other thing, and Steve may have more perspective on that. I mean, I think the other thing is just with respect to cloth masks. Of course, they can be reused. They can be laundered and then worn again. I don't think there's any there's any particular problem with that.
But I'm just asking, so if the cloth mask you leave in the car and then you use it the next day again, is that a dangerous situation? Should we, every time we're out in public with a cloth mask on, then that goes in the wash and you don't read?
Yes, I think in general, yes, that's the recommendation, is that they're laundered or cleaned somehow between wearings. Now, obviously, if you're out somewhere in the grocery store or wherever, and you take it off for a minute and put it back on. I think that's a little bit of a different situation.
Scott, I have a question.
Oh.
Can these surgical masks, if we use it more than once, can we spray with that Lysol spray? Would that help?
I would not suggest doing that because you simply just don't know what you're breathing in. I mean, in particular, Lysol, it's probably not a good and not a good idea. There's been a lot of studies that I've seen where people are trying to look at various methods to disinfect masks, and I think it's fairly involved to do that rigorously. So yeah, I wouldn't suggest doing something like spraying with Lysol.
Okay.
What about using a UVC sanitizer? So we have a couple of the sanitizers that are about yay big that you can put your wallet in or your keys in or your cell phone in.
Mm-hmm.
And you put the disposable mask in one of those and run it through its cycle. Would that effectively kill it? Because it's supposed to be killing the germs on my cell phone.
It may help, but I know UV light is one of the mechanisms they looked at for
No, can't hear you.
Scott, we
Yeah.
lost your audio. Your screen froze. So if you can hear us, Scott, you may want to jump out and back in.
That's all right.
Yeah, we're going to have to end. I mean, it's almost 11:30, and these guys have been very generous with their time.
Wonderful.
I agree. Steve, thank you very, very much for a very informative conversation.
Yeah.
Thank you for answering our questions. And I'd like to give your lives back to you. I'm sure you got other things to do. So we'll close. And maybe there's a way, if people still have questions, they could email them to you or get it to you some other way.
Yeah.
All right. Thanks. And
Good job. Thank you.
have a great day, guys. And thanks.
Thank you, Scott. And
Thank you.
thank you.
Very, very good presentation. Thank you.
Yes, thank you.
Thanks, guys.